Hello, I'm Dr. Rafi Romano. I'm very honored and pleased to present you the sixth part of the presentation of the jaw bracket by Adenta, a lingual bracket, very small one, very nice for minimal to moderate teeth movement. We have already surveyed all the overview of the parameters and the advantages of the bracket, how to do indirect bonding, how to do the bonding in the mouth, and we even discussed all the bending of the wires in the mouth. Now let's pick up a case and try to go step by step in this case of how I proceeded with the bending wires and the bracket bonding in this case. The learning objective is first of all, to learn how treatment planning affect the bracket placement. What is the treatment sequence? Learn from your own mistakes. You will see from all the pictures I am taking in every stage that we can learn a lot from our own mistakes by looking at the pictures and reviewing what we have done. And the third objective that we have is to plan what we move and to move only what we have planned. This is a patient before treatment. You can see that her profile is a little class 3 profile. She has a prominent chin. She has a little retruded profile, retruded upper and lower lip, crowding, very nice exposure of centras in rest position and in smile. We have some attrition and breakage in the incisal edges that should be taken into consideration when we place the bracket and we do our upright of the teeth. We have some crowding, we have some overlapping between the teeth, so we have to plan how we want to solve this case, just by proclination or by extraction or by interproximal stripping, IPR. You can see her bite. She has a normal bite, but when we plan to do proclination, take into consideration that we may get some tendency for open bite. This is the occlusal photos of the upper and lower arches. You can see the overlap. You can see that she has already implants, as you will see in the X-ray, placed on the posterior left segment, and this is already determined by her doctors, and therefore I will not move the first premolar to this area in order not to disturb the position of the future crown on these implants. You can see here the implants are already perfectly located, and I will not want to change the position, especially that the first and second premolars are already on implants. We have already proclination in the upper incisors, which is very typical for a class 3 appearance. So we will not want to do more proclination, at least not at the end result. We may do some proclination as part of the procedure to get a nice arch before we do the stripping and take the teeth back, as we've done in this case. So this is the patient at bonding, and you can see that we have just bonded the bracket in the mouth. Nothing is visible. The bracket is so small that you do not see anything from the back. You can see by looking below the patient, you can see already the brackets. And the patient is biting nicely on the front bracket with a very gentle way, and which does not interfere her. You can see that the occlusion is hardly affected by the anterior brackets. She still has a good occlusion in the right area. In the left area, she doesn't have occlusion because she has missing teeth. But this is very important to look if we have opened the bite or not in order to determine what will be the final occlusion. These are the brackets bonded in the mouth. You can see here that I've succeeded to bond the upper right central incisors in the perfect location, which is in the middle long axis of the tooth, which could be done only due to the fact that the joy bracket is very, very small. So I could place the bracket more mesially, more distally, sorry, in order to correct the rotation, and I did not need to bond it more mesially and then bend the wire to correct the wrong position of the bracket. I did not bond molar to molar because I didn't need to. We have to plan anchor teeth that are not designed to move and moving teeth, and in this case I've decided that 4 to 5, meaning tooth number 24 to tooth number 15, is enough anchorage for this case. Now I've started only with the upper. I always do first one arch to let the patient get used to it, and only a few weeks later I added the lower arch. Here she is in 6 weeks in treatment. I've used nickel titanium 0.012, which is very, very gentle and does already, as you can see, some movement. Look at the, especially the upper right central incisors and lateral incisors, how they slowly move and get into alignment, still without any stripping done, most probably by a little proclination done by the wire. So here is a before, and 6 weeks later, look how much alignment we got from this joy bracket and very, very small wire. Now, after 12 weeks, I'm still with the nickel titanium 0.12, and I have decided that that's about time to go in 12 weeks and to bond the lower arch. Look at the alignment we already got. Same wire, I did not change it. I just do a supervision of the patient, and I got already very nice alignment. We added the lower arch. As you can see, I bonded the protruded central, but I did not connect it into the arch. Why I did not connect it into the arch? Because as you can see, the wire is behind the tooth. So what if I will try to ligate the wire into the slot of this protruded teeth, what will happen? These protruded teeth will have a moment that will try to push her inside. Now, the wire will be trying to push the tooth inside, but there is no space. So actually, what I will need to do is actively push the teeth forward and not backwards. And therefore, we put some brackets for future purposes, but we did not put anything on this bracket. We did not ligate the wire. So here she is after 16 weeks. We put in the upper an 0.016 TMA or CNA beta titanium. And in the lower, I'm now with the 0.012 nickel titanium. I start getting the alignment in the upper and lower. You can see the right central incisors is not only getting rotated, but getting upright. Look at the gum level, look at the long axis of the tooth. Still occlusion, very nice, right and left. Now she has some temporary restoration on the implants, so we can get more nice occlusion in the right and left that stabilize the arch for us. Here she is in 16 weeks. Alignment is progressing. Still, the wire is not fully engaged in the anterior slots, meaning that I still have place for rotation to happen. Look at the upper and lower. Now you can view here that I put between the two centrals in the lower arch, I put a nickel titanium coil spring to open the space. Now, we open the space by proclining the teeth and creating space for this central to be ligated to the tooth. You can look at the overjet. The proclination we have designed is not too much. We don't get a lot of proclination, but we still have enough space gained from this little proclination to align the teeth. Here you can see we are now in the upper with the 16 CNA beta titanium, and in the lower we are 014 nickel titanium and the coil spring to open the space. As you can see over here, slowly we open the space for this left central incisors. You can see the open bite tendency created by the small proclination, and this is very important for us to determine if we want it or we want later on to correct it by doing stripping and moving the teeth further back. Here is the overjet. I try to take pictures from all different angles so I can control all the movements that happen in every stage. If I want to go back later on to previous stages, I can see exactly step by step what happened in every wire that I changed, in every visit that I saw the patient. All this set of photos takes 2 minutes and it goes to the computer, which has a lot of capacity to restore as many pictures as I want. Here she is, the posterior occlusion is still stable with no change, and this is also very important to look every visit of the patient. Now, here she is in 20 weeks. Midlines are okay. Tooth number 11 and 21s are nicely uprighted. You can see that I have still this triangular shape in the incisal because of the attrition she had before. And we slowly get also the alignment in the lower arch. The overjet is still not perfect as we want. We expect it because we have done some proclination. Now here she is 20 weeks in treatment. Slowly alignment is progressing. I'm moving now to upper and lower TMA wire, which is TMA or CNA beta titanium are the perfect wire to create rigid forces but not too rigid, and it's very easy to do these bands. We have done here an elastic chain between teeth 11 and 21 to create a force which will rotate both of them together. Because there is a contact point between them, when you put a power chain, you actually create a force which rotates both of them. Here she is in week 24. Week 24 is around, let's say, something like 6 months, half a year, very fast, very nice. Look at her smile line. I always try to see if my smile line is still nice and attractive. You remember that when we do proclination, we may get the tooth to become shorter, but in this case, the teeth become even a little longer because we applied also some bend in the wire to create some extrusion in the front area, as you can see here, which is nicely shape of smile line. Here she is in week 24. Midline are nice. Alignment is quite nice. Now it's the time to decide about stripping. Do we want to do some stripping and move the teeth back? If we want to move the teeth back, this is a time when the teeth are aligned. You can see here small tips and tricks. I've done here a power chain from tooth 21 to 24 in order to rotate only tooth 21. And I've done the same from tooth 45, 44 to 32 in order to rotate tooth number 32. This is done carefully because the rotation that you get in such power chains are very fast. I try to call the patients when I do such movements every week, every 2 weeks, in order to not to have too much from these small little movements. So here she is in 28 weeks of treatment. Alignment is quite nice. Overjet is still big and need to be improved. And that's about the time that we have decided that we want to do the stripping. So we have taken the enamel reapproximation tools, and now with our measuring gauge, as exists for all orthodontics, I can plan exactly how much stripping I am doing for this specific case. And there are special tools I'm using, like Horico strippers or Comet perforated disc. In order to do this stripping, I'm using fluoride immediately after in order to remineralize the tooth. And I'm using my gauge in order to be precise, to know exactly how much we have stripped. Here you can see exactly the movement done with the strip and how much space we have created. And here you can see the bend I have done in the wire in order to move the two centers, to move them back. There is a step that is continuous with all the shape of the arch. Actually, only teeth 11 and 21 are positioned a little palatal to the wire. So in that way, we can have a true palatal movement of specific teeth. If you want to learn more about all these bands, I recommend you to go back to the lectures on wire bending, where we have discussed exactly how you can make each one of these bands. Now, another thing that should be discussed now is if and when we want to do some composite veneers. For these abraded centers, this is example of another patient, we can create a nice composite veneer where this abraded can be restored. Of course, we can also take polishing discs and just shorten the teeth according to the neighboring one. But that's a decision should be made together with the patient and the prosthodontist to decide if and when we want to do these little aesthetic changes. You will see in the next slide, you can see a speech test I made with this patient, asking her about the problem she had or didn't have with the jaw bracket after bonding and during the whole treatment. I think it is very interesting. It is not so different from other bracket type, but it's very important for you to understand what you should tell your patient about speech problems.
קודם כל, איך הרגשת אחרי ההדבקה? היה לך, כמה זמן היה לך הפרעה בדיבור?
נראה לי שבועיים או שלושה.
ואחרי השבועיים או שלושה הרגשת שחזרת לדיבור תקין? או שיש לך עדיין...
עכשיו אני חושבת שזה תקין לגמרי. היו לי תקופות שזה היה יותר טוב ותקופות שהיה פחות טוב.
ואנשים היום מרגישים?
היום אני חושבת שלא מרגישים.
In summary, what we have learned. First of all, we learned that the more precise bracket placement, the less wire bending. It's very important, better to rebond rather than bend wires. So if you see during the stages of the treatment that you have to bend the wire again and again and again and again, rebond the bracket. Speech will come back to normal after 2-3 weeks. And the last recommendation, take follow-up photos every time patient comes. Keep them and go back when you see problems, when you want to encounter and to learn from your own mistake, or when you want to show the patient how much you have progressed from the start, because patient tends to forget. Bye-bye.